Okay, so my job is really easy. Fidel had gone through all the pearls of choosing wisely in cancer care. My job, my talk will be based on this choosing wisely campaign that had been going on in many African cities. Actually, not only limited to Africa, but even to East Asia. There was a conference in here in Senegal, Cambodia, in Far East Asia. There was a conference in Tanzania and all that. So I'm going to capture all that and wrap it all to in line with the choosing wisely principle. So definition had already been done, but I want you to focus on the second paragraph because this is what matters to us. The care in high-income countries and low and middle-income countries are very different, even though the evidence is the same, but implementing that really wraps around choosing wisely. So it's an initiative that seeks to advance a dialogue on avoiding unnecessary medical tests, treatment, and procedures in cancer care. So Fidel had shown this. It's highly published. There's Choosing Wisely India, Canada, Philippines, and even Brazil. And really the mantra and the concept is all the same. So I wanted to start with this. If we want to choose wisely, that means we're coming from a point of evidence and data. So in this landmark study, really, you see data estimates a major increase in cancer mortality, from those figures in 2020 to about 1 million deaths by the year 2030. So with that in mind, really, we need to really be choosing wisely in everything we treat and we diagnose and we follow up. Okay, so a little bit of health economics. Again, you put your money where your mouth is in the spirit of choosing wisely. In the healthcare system in Africa, we know it's underfunded. A case example is this data, $10 per head for population in Africa. Contrast that with over 150 million population of the developed world with that amount of funding. So how then can we trust guidelines or choosing wisely mantras that are probably not in line or in tune with the current systems in healthcare systems in Africa? So we can use that definitely as a reference and maybe pick and choose in the spirit of choosing wisely. Fidel had mentioned this, and I will not go through it, same thing. But why do we need all these choosing wisely principle? Because it will really affect the whole quality care, either underuse, overuse, or misuse if we don't choose wisely. An example of underuse is the failure to provide healthcare service when it will have produced a favorable outcome for a patient. Case in point, when you don't use a neoadjuvant chemo in a patient that you really know will not benefit from upfront surgery, okay? Overuse is when you actually use the available evidence or healthcare services under the circumstance in which a potential, it's actually even causes more harm than good by overusing it. That means, for example, giving chemotherapy in the last months of life, overusing chemotherapy in hormone receptor palliative or positive breast cancer. Again, not addressing the biology of the disease and going straight to chemo causes more harm than good. For example, an elderly lady who has an ER positive or hormonal positive breast cancer, we know her biology is driven, of her cancer is driven by the hormone status. In the spirit of de-escalation therapy, she could get away with actually just, endocrine therapy. Misuse, on the other hand, occurs when when appropriate service has been selected, but a preventable complication occurs and the patient does not receive the full potential benefit of the service. For example, avoidable complication of surgery or medication use, not adjusting for renal or hepatic function. Again, Fidel had mentioned this. Don't ask for a test for asymptomatic patient, especially in a disease biology that really a scan will not help, at least in that particular time. MDT, we cannot underscore how important it is. Surgery as initial, instead of first of all debulking the chemo, maybe with neoadjuvant chemo. Do not initiate without staging the cancer, because that determines the type of treatment. don't remove a breast lump without histological confirmation or malignancy unless there's a need for biopsy. This very important prostate cancer in the early stages. Active surveillance is actually a form of treatment. It's different from watchful waiting. Active surveillance meaning here you're ready with your guns, go, but only when necessary. Okay, these are all choosing wisely principles. But do not delay palliative care for a patient with a serious illness who has actually physical, psychological, or social or spiritual distress because the patient is pursuing disease-directed treatment. There's this mantra of associating palliative care and end-of-life with end-of-life care. The preferred term is primary palliative care, which means it starts right at the diagnosis. You address anything and everything that you'll have done in end-of-life care in the earlier phase of the disease. Systemic therapy, solid tumor patient with low performance status. Someone is really having low hepatic function, low renal function, and general poor nutrition status, and you give them chemo, which is really toxic. You're doing more harm than good. This is also another principle that is more poignant in Africa. When you do longer courses of radiotherapy, where actually the evidence supports a shorter course of radiotherapy, that is not only not choosing wisely, but also wasting resources in a place that really needs that resource. Okay? For example, giving multiple fractions of palliative radiotherapy while one can do. So my job was to summarize these conferences, the takeaway and lesson learned. So there was one in Senegal, as I had mentioned. There's another one in Tanzania. There's another one in Cambodia, I think. Nigeria. So the lesson learned from all this is that we really need to be guided by the evidence, especially in low and middle income countries where resources really are very important. Why is that? Because the expected outcomes of the evidence that we use will actually be determined by the safety of the data, of the recommendation you're giving for the patient. Effectiveness, it should be least detrimental, and it should be tailored to improve acceptability and improve outcomes as well. So the evidence which goes with the choosing wisely principles really in Africa or in low and middle income country is kind of different. You remember I started with the health economic question of a $10 per patient in Africa, give or take. So when the evidence that we use in low and middle income country are mostly generated by high income countries, areas of interest are dependent on priorities of agencies that are driving that agenda, diseases burden which are very different, and disease biology which is completely different, industry rivalry and poor design trials that don't fit the principle of choosing wisely, lack of data in trials in low and middle income to even improve that desired outcome. When you see all this, then it's really a problem when you go ahead and choose any evidence, any guideline without interrogating it to the local needs. Well, if you look at the left side of this slide, utilize the best external evidence. That's not to say that we don't follow any high-income country evidence. NCCN, I use it on my daily basis, ASCO guideline, ESMO, but I tailor it to my local needs and to the local population, preferences. So the other area that was covered in the conferences was tackling low volumes of clinical trials in Africa. We know clinical trial is the cornerstone of cancer care, but you see there's a huge demand and unmet need of clinical trials in Africa. This is because there's a limited progress in understanding the African genome, which will have actually affected which type of trial to even carry to begin with. There's lack of suitable medical solutions tailored for African population. There's a slow development of African healthcare system, and there's an availability of data that will actually drive the need for the clinical trial. Okay? So while all these are missing, and when this important ingredient is missing, then doing a trial outside the basis of this will not be meaningful. Similarly, in the spirit of choosing wisely, a lot of life-saving cancer drugs are not available in most of the centers, so we need to choose properly. In this talk given by Dr. Chua, he's talking about availability, affordability, and accessibility, and even the administration feasibility of this medication to be driven by how we choose them. So there's also radiology, which is really, really important and in terms of assessing and diagnosing cancer. So we need to choose based on types of malignancy, stage of disease, size of the lesion, aim of the imaging, availability, and accessibility. Something like PET scan. There are very few countries in Africa that have PET scan. But if you make that as your first choice of staging, a cancer disease, then it might be not the right thing for the right population at that time. So there's also palliative care. There's a lot of palliative care team in the crowd. Dr. Ntizimira, who is here, talked about this beautiful concept of Ubuntu coming together in palliative care in Africa, which is a form of choosing wisely based on culture. So there's this butterfly model, and then there's this safari concept of, I think 10, looks like more like hallmarks of cancer if you look at it. But it's more like, hallmarks of palliative care in African context. So why do we need all this? Because if we do not choose wisely, it must be coming from somewhere. Is it because we don't know what we're doing, or is it because we know actually what we're doing, but we don't want to do the right thing? So there's this no gap and the no do gap. So the no gap is that you know everything, but no gap is that people don't even understand the importance of choosing wisely. Well, do gap is that you know the thing, but you're not doing it, okay? Because of probably high volume clinics and high volume workload in most of African setting. The oncologists are really, really busy because they're very few. There's a dual practice, usually in private and public practice. Inadequate quality monitoring of the metrics, lack of motivation, and inadequate training in communication in choosing wisely. So these are some of the gaps. The role of the workforce in implementing choosing wisely in cancer care is very important, because there are many reasons that patients in any given healthcare system do not receive evidence-based, as I've mentioned in the previous slide. So in what way does the workforce fail, really, to provide these needed evidence-based choices? So finally, lesson learned is that we really need to practice ways that we can help our patients by following the guidelines that are in tune with the local need. And we also need to practice low-cost detection and treatment strategies, for example, in breast cancer, especially in patients in low and middle-income countries. This is not to say that they should get the shorter end of the deal, but at least, there's a cost. Cancer is a very expensive diagnosis in Africa, okay? And then advocacy should wrap around choosing wisely, because if you don't advocate for patients and the real correct mantra of choosing the right thing, then we might not really drive this agenda forward. So there's a similar concept that is tied at the hip of choosing wisely. It's really just using your common sense, okay? And this is actually a new concept put forward by the team from Queen's University. It's called common sense oncology, okay? As they say, common sense not so common. So we need to focus more on the outcomes that really matter in patients. And that's the team behind the Common Sense Oncology. Dr. Fidel here is one of them. So in a nutshell, we had published all a conference report paper about the choosing wisely when we went around all these places. And the conclusion is that we need to believe that healthcare delivery is transitioning actually from a volume-based to a value-based care. Dr. Fidel gave a very good mathematical definition of what value is, quality, hence choosing wisely. So emphasis should be around on the discussion on ways to select more cost-effective and high-value treatment interventions and to minimize financial toxicity. Africa is a large continent with different healthcare infrastructure and systems, resulting in high variability in healthcare access, hence the need for choosing wisely. However, there's a lot of similarities in terms of the resources and practice setting. Thank you so much.